Good afternoon, good evening. Thank you so much for joining us for the weekly press briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing covers health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Manager at the IMST based in DRC. I will now hand it over to Prof to start the session. Over to you, Prof.
Thank you, Margaret. Good morning, good afternoon, good evening, colleagues and journalists. I will be presenting on behalf of our DG, Excellency Dr. Jean Kaseya, who is currently in Washington, D.C., attending the IMF World Bank spring meetings. So we'll first share our condolences with the Vatican community and the Catholic community for the passed away of the Pope Francois. He has been a great advocate for peace, and even Sunday he was praying for the peace in Africa, especially in DRC, where we are responding to Mpox. And I will thank you, the journalist, for being there every Thursday at the same time to take the right information to serve as catalyst, and also to all our teams of the IMST, the member states team who are responding to Mpox, but to all those other outbreaks that will be presenting during this press conference. Over to you, Margaret. A few weeks ago, the DG was presenting the new African financing strategy, where we are relying on 3 pillars. The first pillar is to increase of domestic funding and financing. The second one is the alternative funding, which will come for diaspora bonds as an example, but also tax from the air ticket. And the third one, which rely on blended financing with the private-public partnership. So this week, we were really happy of having the chair of the African Union, His Excellency President João Lourenço of Angola, who pledged $5 million to Africa CDC. So that demonstrates the strong continental leadership and solidarity toward domestic financing of public health. So Angola is really championing the Africa-led financing strategy, and especially the pillar on the domestic financing. 20 years ago, African countries have committed to spend 50% of their GDP into health. This was the Abuja Declaration. And since then, 3 countries out of the 44 member states in the continent are actually doing that. So this is an opportunity for our country to follow the example of Angola to increase the expenditure on health, especially considering the new era that we are in. Next slide. So talking about this new era, as I mentioned, the DG and the leadership team is taking part of the World Bank and IMF spring meetings, where they are discussing with the Ministry of Finance of Global to see how we should navigate considering the cuts that are happening, the new opportunities, and to see how the Africa Health Financing is going to find its space in this new era. Next slide. So we believe that next week, when the DJ will be back, we'll have more outcome on how Africa CDC, the continent, will benefit from this challenging environment. Now, let's get back to Mpox in Africa. So here we have some promising news. You can see that the number of cases notified has increased compared to last week. And this is partly due to the intensification of the response that is happening in many countries, in DRC, in Uganda, in Sierra Leone, in Burundi. And it's expected that because of the deployment of community healthcare workers and the active tracing will keep increasing the number of suspected cases. And as you see, we will hope that we'll continue to have the decrease on the number of confirmed cases. Nevertheless, this week, we have Malawi that has reported its first ever case of Mpox. We'll come back to that. So now we have 24 countries that are reporting Mpox since 2024. 17 out of them are on the active phase. But what is important to notice If we compare 6 weeks after the facts, that was in October 2024, and the last 6 weeks, we can see a decline in the number of suspected cases, but also the confirmed case. This is due partly to Burundi, but to some other countries. Next slide. Now, DRC has been and remained the epicenter of this outbreak. And even in DRC, when we do the same comparison, in October, we were around 2,212 suspected cases per week. Now we are around 2,000. So there is something that is happening that needs to be pushed at the level of the suspected case, but also the confirmed case. So there is a trend that we need to continue to push. And this is happening despite the low testing coverage. So you can see that we've increased the number of suspected cases, but much effort has to be done, and it's being part of the intensification so that the community of care workers, the epidemiologists, and the team in the ground ensure that all the suspected cases, all the alerts are actually validated, and therefore the people are sampled. The sample must be collected, sent to the lab. Therefore, we will keep on increasing the testing coverage so that we are confident that we have the total picture of what is happening in the ground. And when we compare to the previous 6 months, as I mentioned, we can see a decline in the number of cases. So we'll need to keep on monitoring it very closely and ensure that the intensification confirm what we are starting to see. Next slide. Now, this is just one example of the intensification. We've been talking about community healthcare workers. What does it actually mean? In Kinshasa, for example, we deployed 226 community healthcare workers in the hotspot zone of Kinshasa. Hotspot mean those are the area that will have the highest number of cases. They will represent around 80% of the case for the entire Kinshasa. We'll continue the same thing in the other provinces with WHO, with UNICEF, with SANRU, with other partners, all behind the Ministry of Health, who has validated that intensification strategy. And basically, we are moving from a phase where we were doing a passive surveillance, meaning that the patient will come to the hospital, and that's where we'll take care of them. But when they come to the hospital, it's already late. It means that they've been transmitting the disease within a community. Now, having the community healthcare worker deploy, moving household per household, doing that active tracing. One, we can capture the case early enough, we can stop the transmission, and as you can see, the number of contacts is increasing. From 1.7 that we reported a while ago, we have an average of 7 contacts per case. This is an average. So we have some provinces where you can have 20, if not 30 contacts per case. So that is a good trend. If all our cases are coming from our contact list, then we control the outbreak. And the other advantage of having the contact is to ensure that we have a targeted approach for vaccination, which means we'll focus first on the contact and the contact, but we also focus on the higher risk population, the sex workers, the truck drivers, depending on the country, those who are the most at risk because of their condition, but also those who are the most exposed to transmit the disease, to spread the disease all around. So currently, 754,000 doses has been delivered, and the country has requested and will receive 300,000 additional doses in the coming weeks. That will allow them to carry on the vaccination. On top of that, they have a bilateral agreement with the Japanese government, who is currently in DRC, so that they can use the LC16, another vaccine validated by WHO, to reach the 3.4 million people that is part of their strategy. But this has to be done in a targeted approach, focusing on the most at-risk population, the most vulnerable, and those who are most likely to transmit the disease. This is well written in the plan of the country, but has to be implemented. So now the micro-planification that is ongoing with the support of the different partners is to see how we can go back to the key values. Remember, the key values has been exposed to the humanitarian crisis, and therefore not accessible. But at the same time, it is the place that is carried the highest burden in terms of number of cases and confirmed cases. So going there to implement all the activity, including the vaccination, is really the turning point to the response in DRC and therefore in the continent. Next slide. Now, as you will see on the right side of the map, you see North Kivu, Sud Kivu. In the middle, you see Trapa, you see Sankuru. So the hotspot area for Mpox on the left and measles on the right are the same, more or less the same. So we are responding not only to Mpox, but also to measles. And there is no way you can clinically differentiate a kid with Mpox and the one with measles. So we need to integrate, which we are pushing, at the level of the detection with what we call the multiplex testing. So the idea is once you have a suspected case, you should be able to do at the same time a test that will tell you whether it is Mpox, measles, or chickenpox. Therefore, you can adapt. You can adapt the detection. You can adapt the IPC, the infection prevention and control. You can adapt the case management, the treatment, but also the vaccination. And we are glad that UNICEF has managed to send a large quantity of drugs in the North and South Kivu, which will allow the country, when ready, to implement the vaccination. So we'll be looking at the dual approach, integrated approach of vaccination. We have measles on one side, we have Mpox in another side. Remember, I mentioned that the micro-planification now is really targeting the North and South Kivu because those are the high province in terms of number of cases of Mpox. Next slide. On the 16th of April, Malawi has reported the first ever case of Mpox. This morning, we were having at the IMST a discussion with the team in Malawi to understand the way they are responding, the way they are organizing so that we can provide appropriate support to the team. So far, they have 4 confirmed cases. 3 of them are adult. 1 is a child of 2 years, and none of them has a recent travel history, which means that there has been a circulation of Mpox within the country. So there will be an important challenge on the surveillance to track and find the clusters where those cases are. And as I mentioned, 1 of the 4 patients is a children of 2 years. That highlights the need, as we've already mentioned, of countries to approve the vaccination for children between 1 and 12. Most of the countries have accepted the vaccination for 12 and beyond, but the need also, as DRC has been doing, starting from 1. And it's safe, it's pretty safe. The monitoring of adverse event is happening in all those countries, but what we've seen is that there is a very low proportion of adverse event. So it's an important opportunity to make that advocacy for all the countries to consider the approval for vaccination in children that are at risk. Now you have 1 out of 4, 25%. It's unimportant. Next slide, please. Now going to Uganda. Uganda, we are also seeing some promising trend. We can see a reduction of the confirmed case. We can also see a reduction of the confirmed case, death, sorry. And death are people who have comorbidity. Most of them, half of them actually, are people living with HIV. So that has led the country to really emphasize in the integration response with the people working on HIV, also because the most at risk and the most exposed are the sex workers. And some of them are also living with HIV. So having that joint, that integration, that integrated response is critical to ensure that we detect early enough and ensure that the people living with HIV and having Mpox have adequate treatment, adequate care, and also are the ones that should be prioritized in terms of vaccination to make sure that they are protected and therefore reduce the case fatality rate, at the same time limit the spread of the disease. So Uganda is also the country that has received 100,000 doses of vaccine. And so far, as we'll see later, they have absorbed around 61% of those vaccines, which is going to contribute to the decrease of the case that we are seeing. Next slide, please. Now in Kenya, we are also monitoring Kenya. Kenya is a country close to Uganda. And there is a lot of transit with the truck driver. And we know that the truck driver are also, while traveling, transmitting, carrying the Mpox. So discussing also today, during our meeting with the team in Kenya, they've also highlighted the challenge that they have in terms of surveillance, in terms of identifying the contact around the case, because the sexual network is quite difficult to monitor, but also some challenge that they have in terms of laboratory, in terms of isolation. So the different partner will support the country to see how to increase and implement the response. The good news is that they received the vaccine recently, and we are working with Gavi so that they can allocate the required operational funds so that Kenya also can be able to scale up the vaccination targeted to the most exposed and to case around the contact. Next slide. Burundi. Burundi is definitely the best example in terms of the response to Mpox so far. We can continue seeing the decrease in the number of suspected cases. Same thing for the number of confirmed cases. Number of deaths, we have no death last week. A testing coverage of 94%, positivity 47%. So it's really a good example of how they've managed to deploy, to intensify the response with the community healthcare workers. So ensuring the community is really at the center of the response, but also with the deployment of the laboratory. So this has been the intensification. And as you can see, if we go back again, 6 weeks after the declaration of the facts in October, we were reporting 200 cases per week. Now we are at 30 confirmed cases per week. So that is a significant decrease and a very good example. That was happening because of the intensification of the response. Next slide. So now the country is moving from intensification to the legacy. The legacy means that Burundi will be a different country after than before the Mpox outbreak. Last week, and early this week, they were finalizing and validating the National Decentralization Plan for Mpox diagnostic. What it means is that they have a clear algorithm of how Mpox diagnostic is implemented at different levels. At the lowest level, in the district where you have the point of care, including expert, that will tell whether the suspected case has Mpox or not Mpox. Now, knowing that with a positivity rate of 40%, which means 4 suspects out of 10 are positive for Mpox, the remaining 6 also need to be considered. Therefore, those negative will go to the highest level where they will have the qPCR, and then they will be able to do the multiplex and find out, is it chickenpox, is it measles, is it something else? And at the capital level, they will have the sequencing. So the country has a plan on clearly defining the role and the responsibility of all the actors involved in the diagnostic. So this is really aligned with the legacy of the Mpox Continental Response Plan 2.0. So this is a very good example, and we really commend the Burundi for that. Next slide. Now, in terms of vaccination at the continental level, we still have 10 countries that have received the vaccine, 7 countries currently vaccinating. The last one to start was Liberia. South Africa is planning to start in the coming weeks. 600 people have been vaccinated so far. In DRC, 23,000 doses has been received in the 18th of April, but there are 300,000 doses that are planned to be received in the coming weeks out of the 500,000 of those that have been allocated to the country. And as mentioned, they have a bilateral agreement with the government of Japan for the allocation of 3 million doses of vaccine, and the training is being prepared as we speak. But with all those doses, still, the approach will have to be targeted and ensure that we focus on the most at-risk population, the most exposed, and those who have the most likelihood to transmit the disease. We talk about the sex workers, in some place the truck drivers, and all the population that has already been identified, and that as part of your country strategy. So now the must is the implementation of the strategy according to the targeted. In Uganda, as mentioned, they've resumed the vaccination, and really they've been doing well on vaccinating 61,000 people in the most affected city of Uganda, and they will start the next round on the 28th of April. They've requested 200,000 doses of vaccine that will be available for the country in the next coming weeks. Next slide. The Diagnostic Advisory Committee of Africa, CDC, is working on the game changer, which is the rapid diagnostics test. So this is a small cassette, which in 15 minutes can provide you the result whether a suspected case has Mpox or not. And this can be used at the lowest level of the community without the need for power, without the need, with a little training, and the community of workers can be the actors. So we've been a long way. The first result last year was giving a sensitivity of 23%, which means if you have 10 people having Mpox, the rapid test will detect the Mpox on 2 out of the 10 persons. That was last year. So now the manufacturer have improved, and they send back the new product, Contifama, Revital, so that they can be assessed again and to see what is the new performance so that they can be procured, deployed in different countries, and be a change maker in the response. Because then the result will happen in 15 minutes, which means all the IPC, all the case management will be done within a day. While now we still have some sample that will last 30 days, if not more, from the time they are collected to the result to come back to the patient. And within 30 days, it's almost not necessary because the patient, if he's in the community, he has spread the disease or he has not been taken care of. So we expect to have the result by the second week of May. We'll provide it to you and definitely find a way to implement in the country if the results are what we are expecting. Next slide, please. From Mpox, we move to cholera. And for cholera, we have 2 different situations. We have the cholera in Sudan, where we can see a decrease, tiny decrease of the number of cases, the number of deaths, though we still have quite a number of them. 93% of the deaths are happening in the health facility, which is important to highlight as we move to the next slide, where we see the situation in Angola. Next slide, please. In Angola, we still have a slight decrease in the number of cases, but they remain still high despite all the effort of vaccination, active tracing, and so on. And as you see, we have 67% of the deaths that are happening in the hospital, which means the 33% are still happening in the community. So there is still a delay between the detection, the care, and the management of patients in the community. And this situation really raised the attention and the need for a more coordinated response between the different organizations, Africa CDC, WHO, as we are doing for Mpox. And this is a conversation that is ongoing to see how we can just all of us move in a coordinated approach in Angola to ensure that we see the same result that we are seeing in Sudan. Next slide. In Uganda, we still see the increased number of cases. There are 4 cases as compared to 1 last week of anthrax, with a cumulative confirmed case of 20. This is important to highlight the One Health approach, mentioning that we are responding to some of those outbreaks, which are zoonosis. Next slide. Still in Uganda, we are really counting the days. In 2 days, on the 26th of April in Bali, if all goes well, and we really keep our finger crossed, the country will declare the end of the Ebola. And we really need to commend Uganda. Just to remember, we had 14 cases, 12 confirmed and 2 probable, with a recovery rate of 83%. Knowing that Ebola is the disease with the highest case fatality rate amongst the different outbreak and epidemic that we are handling, usually we are around 60–70% of mortality rate. Here, the country have managed, with the support of all their partners, to have the very high recovery rate. They've managed to have a great surveillance with the high number of contacts, 634, which is definitely more than the 20 contacts per case. But they went even further with what we call the mortality surveillance. So once they have ensured that they had all the contact of the case that have been confirmed, they went backwards, like 3 to 4 months before the declaration, to find in the sample, to find in the register, if they have no patient that has been missed, and they find no case identified. So that is a really great example of using surveillance and using research and evidence-based. The treatment, the vaccination research have been taking place during the outbreak, and that will be an added value to the next outbreak, because we know that there will be other outbreaks, because we are working there. It's an environment and ecosystem where the human and some of the reservoir are living quite close together. So we really commend the country for this great response. Next slide. And on top of that, they were also responding, and they're still responding to the Mpox. So the integration approach for a response is also important to commend. On the side of the capacity building, relying on the community, we will not stop remembering that the community is key. That's why we deploy all those community healthcare workers to work to respond to Mpox, to Ebola, but also to cholera in different countries. So with that approach, they've managed to respond to the 2. So we've seen the Ebola declaration in 2 days, and we are also seeing some promising results on the side of Mpox. So we hope that we'll keep on pushing, supporting the country. There's a mission that will go there next week by the IMST to continue to accelerate the effort of the country to provide some assistance, some resources, so that we can also go toward the end of this outbreak. Next slide. In summary, the continent, Africa, continues to face many outbreaks. We've seen Mpox, cholera, Ebola is toward the end, anthrax, and many more. Malawi has reported 4 new cases, which means we have now 17 countries out of 24 that have an active transmission of the disease. And this means that despite the trend that we are seeing a decline in suspected case, in confirmed case when we compare to 6 months before. But we need to accelerate. We definitely need to carry on the intensification. And that means resources in terms of funding, in terms of vaccine. Because those countries, Uganda has requested 200,000 doses of vaccine. DRC has requested 500 doses. And we have those new countries. We have Malawi, we have Sierra Leone, we have all those countries that we need support in terms of implementing all the different activities so that we can stop. We can learn from the good experience from Burundi, from other countries, so that we move towards the end of the declaration. So on the 17th of May, the ECG, which is the committee advising the Africa CDC DG on maintaining or lifting the effects, will sit. And they will look at the evidence. Where do we stand? And our goal is to really push, intensify, so that when we reach there, we are in the best place, in the better place in the response to the outbreaks. So I thank you all, and over to you, Director Margaret.
Thank you very much, Prof. Let's take the first two questions. We have a question from James Kunda from Anadolu News Agency. The question is, with Angola leading the way, what would be your message to other African nations to lead voluntary funding support to Africa CDC? That's the first question. The second question comes from Pedro Alonso, a reporter for Spanish News Agency. So the question is about the end of Ebola outbreak in Uganda. Is it confirmed, the date that you spoke about? That's the second question. I'll hand over to you for your responses.
Thank you, Margaret. So definitely Angola is showing the way. We really appreciate the leadership of the president, which is the chair of the African Union, which is aligned with the new Africa health financing, where we really want to push the agenda of domestic funding. And it's not there's nothing new. The Declaration of Abuja is 20 years ago, where country has committed to spend 50% of the expense on health. So what with the cuts of the US government and other funders, actually, we are pushed to the corners. But this is an opportunity for country to rethink how they should take care of their communities. And we are glad that Angola is showing the way. And as the chair, he will push his brothers, president and head of state, to support Africa CDC. We already have the African Epidemic Fund, and those actions will support Africa CDC to have access to more resources. We have seen Angola, we have the cholera, we've seen Sudan cholera, we've seen the Mpox, and with all the cuts, countries will have to take over their health. And we've not talked about HIV, who was relying on PEPFAR and others. So the domestic funding will allow countries to be autonomous and independent and to take care of the community, which is something that is upon the government. So to Pedro, so as far as we know, and we really keep our finger crossed, because there has been, I think, one country, Guinea, a few years ago, where they had a case that was declared 2 or 3 days just before the celebration. But so far, it's the 26th of April, which will happen in Bale, in the eastern part of Uganda. Over to you.
Thank you, Prof. Let's cross over to the floor. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello. How are you? Can you hear me?
We can hear you. Go ahead.
Good. Thank you. Thank you. So just yesterday, the health authorities here in Sierra Leone spoke to the press, and it's still not good. I mean, the future is not good. Mpox cases are flaring up, but then the only arsenal we have, as one of them put it, is the vaccine. Sadly, the vaccine is not enough, and this has been said several times. So I was just wondering, what could a country require for, I know the Africa CDC is asking for vaccines. What could a country require for it to reconsider to increase its vaccine supply? We have already got an allocation, but we haven't got all. We got some. We're expecting the rest. But is there any chance for a country like Sierra Leone to have more? Because we really do need more. Thank you.
Thank you, Kemo. Let's take the next one before Prof comes in. We have a question here on domestic financing, and the question is, what concrete strategies can governments adopt to sustainably increase domestic health financing in the face of declining donor support, especially for emergencies? Over to you, Prof.
Thank you. So to Kemo, this is a very good question. So it's important to highlight that we recommend vaccination, but vaccine is not a silver bullet. We've shown the example of Burundi, who have managed their response without the vaccine, but this is a specific case. They've relied more on the active surveillance, the lab decentralization, and the good IPC, which means isolation of cases as soon as we find them. And Sierra Leone is implementing a good response. They launched the operation Find Them All by the deployment of community healthcare workers trying to actively track the patient in the community. At some point it was stopped, but we've heard that they have resumed. We have a team that will be there next week to support, encourage, and provide some resource to the team in Sierra Leone. So we believe that all those activities will help the country to use all the different pillars. Vaccination is one out of 10 pillars of the response to Mpox or to other outbreaks. Now, on the side of the allocation, definitely the allocation will rely on how the outbreak will continue. But it's important to know that the number of those available at the global level is quite limited. That's why we really encourage a targeted approach. So we've seen, for example, I think around 700 people have been vaccinated in Sierra Leone, but it is critical to vaccinate the right population, which are the most at risk, the contact and the contact, also to vaccinate the sex workers, all the people who you find are positive within the epidemiology. So that's the kind of support that is being brought to the country so that they use the resource that we have. Now we are in an era where we need to do more with less. So this is the support that the IMST will provide to the country next week. So the second question was about the domestic health financing. So there is no one-fit-all approach. Each country will find the best way, the most efficient way of finding the resource. Some will rely on social bonds, some will reduce the expense in other sectors. A country can decide to take some money from the defense and to invest more in health. And some countries were actually spending less amount of money in health simply because they were receiving support. So now that the support is no longer there, the equation is different. They will therefore have to address and change their strategy. Over.
Thank you very much. Let's take the next question. It comes from Dorcas Wangira from BBC. The question is, on April 16, the Intergovernmental Negotiating Body finalized a proposal for the WHO Pandemic Agreement. The draft, described as a generational accord to make the world safer, is now ready to be adopted next month by the World Health Assembly. Are there any takeaways or points of action for Africa CDC from this? That's the first question. Let's take the next one. The next one comes from Nicholas Barrio, a reporter from the Wall Street Journal. The question is, what has been the impact of USAID cuts to response efforts to halt Uganda's Ebola outbreak? Over to you, Prof.
Okay, thank you. Thank you so much for the question. To Dorcas. So the pandemic agreement is being ready, but some conversations are still going on in Washington, D.C., as I mentioned, where the DJ is with the leadership of Africa CDC to see actually how the implementation and what will be the role of Africa CDC on that. So I'm confident that next week, while he will be back, he will give all of us some outcome of that visit. So now the impact of USG government in the Ebola. So Uganda is a country that has been well supported by the US government, and especially on all activity from the sample collection to the sample transportation. So they are having what we call a centralized approach, where the samples are collected within the community and go to the, let me call it, the beautiful lab that they have in Kampala. So now the cuts were really affecting how the sample were moving from the community to the lab. However, the country has managed to mobilize domestic resources actually with the other partners so that to reduce significantly all possible delay. And as you've seen, they have been doing a great job on surveillance, going even backward to ensure that they've not missed any case. So these have then affected other response, the Mpox response and many other outbreaks, because the focus was really on Ebola, because we know that the case fatality rate is quite higher. And then also because the economic impact of an Ebola crisis is much higher. So they've managed to prioritize the resource that they have, focusing on Ebola, therefore limiting the impact of the USG cut on that response, but definitely affecting the response to other outbreak entities.
Thank you, Prof. Let's get crossover to the floor. We have Charles Chikapa from the Community Radio Initiative in Malawi. Charles, if you can hear us, you have the floor.
Thank you very much for the presentation and the updates. I'm from Malawi, as you have just rightly said. And just last week, we got this information that new cases have been recorded. Now, listening to
Hello, Charles, we lost you.
You've talked about community, bearing in mind that in Malawi, most of the population on the... Sorry?
We lost you at some point. If you could just restart your question, please. Thank you.
All right. Okay, fine. I'm saying that we got news about the new cases some 2 weeks ago. So I'm interested to hear more about the community, you said village training sessions for surveillance purposes that the doc has just mentioned. How do they work?
Thank you, Charles. Let's take the next one before Prof comes in. We have a question here about the clinical studies that have been conducted so far. So the question is, can you update us on some of the scientific research work coordinated through the IMST in the DRC? You have previously referred to 48 ongoing studies. Over to you, Prof.
Thank you. So Charles, our colleague from Malawi. So the community healthcare workers are people who are from the community. So they are people who already have some sense, some involvement in managing health. So they are not doctor, they are not nurse, but they have an interest on health. And those people have taken some responsibilities supported by the Ministry of Health, supported by the different partners. And in the specific response, as Mpox is confirmed, so those people will move from household to household to show the pictures of what is Mpox, so that people who are not aware of what Mpox is will see, okay, this Mpox means that we have rash. So if we say, okay, here I have a cousin, I have an uncle who has the rash, so I need to bring that person to the hospital or to communicate to the community healthcare workers. That's the first thing. Now, when they will identify a suspected case is someone who have the symptom. So they will be the one to list the contact. So they will say, who are all those people who have been in contact with that case, so that they can monitor them. So the community healthcare workers will also be the one during 21 days to follow up every day or every 2 days to see how this person is doing. Because when you control the outbreak, it means that you have all the contacts of a case, and the new case will come out of the people that you monitor. which means you can implement the isolation, you can follow them up, and also they can provide the list of the contacts so they can be vaccinated. So the community healthcare worker or the village health team, depending on the country, are really critical in the response because they send the good information, to do the active tracing, but also they are the one to support and ensure that we have a more targeted approach in terms of vaccination. So for the clinical study, I will let my colleague, Dr. Musoka, respond to the update on the clinical study.
Thank you so much, Professor Yap. It's true. So let's start with the therapeutic trial, the only therapeutic trial with the presented forfeit. We have around 16, 18 candidates that have been recruited. Our first objective was the safety. The data safety monitoring board has met, and there are no adverse effects. The ages range from 2 all the way above 30. We are in the final discussion to move the trial to Uganda, because once we recruit the 40, 50 participants, we'll do the second review of safety. And then once we get to 100, we'll start to look at the efficacy, the time to resolution of lesions. So it's progressing well. You also know that one of the studies, I will not speak about, but I'll just highlight some. We're discussing the 12 to the less than 17 to 11 years old. The 11 and below, samples were collected. The good news was that the data safety monitoring board approved the study, so children less than 12 years old could get the vaccine without adverse effect. And so the sample has been collected. They will be shipped, so we can look at efficacy. But in terms of safety, we now know that children below 12, at least from this research, can take the MVA vaccines without adverse effect. And so that's the second study. We've managed to collect over 9,000, 10,000 data from about 6 countries across Africa to look at the perception towards vaccines acceptance. And that is been analyzed now across the region. In about 1 or 2, we'll be able to look at the perception of health-seeking behavior towards Mpox and the vaccine, which is critical for uptake of vaccines. So that is ongoing. We're in the final stages of looking at the pharmacovigilance protocol. The team has been recruited, working with a university in DRC to follow the patients on the adverse effect. So that is progressing very well. Essentially, those are where we are. Once we can launch, we are in DRC this week to try to launch the epi transmission dynamics study. We'll be able to share the information later. The team in Burundi has shared some very excellent result of the transmission dynamics, looking at a centennial site of Ebola and hemoseeking behavior. The results are very encouraging to explain the dynamics of transmission in terms of the epidemiology of Mpox. So these studies are progressing well, and they are providing us information that is helping us to shape the vaccines, especially those below the ages of 12. We know that it is safe. We are now working on the efficacy trial. In a matter of months, we'll be able to come out to see if our Brazil is efficacious enough to use as the first therapy for Mpox. Thank you very much.
Thank you very much, Papa. You know, research is critical to allow us to have an evidence-based response so that we can rely on those data, on those evidence to shape the response, but also to prepare the next outbreak, because this is not the last one. So we really commend all the colleagues working on research, which also require more resources. As Papa was mentioning, they are planning to launch the study now going back to Uganda, and which will definitely need more resource for those studies to be implemented, those results to begin, and the response to be improved. Over to you, Margaret.
Let's cross over to the floor. We have Benedict Omondi from Imani Radio. You have the floor. Benedict, can you hear us? All right, let's take 2 more questions here. We have a question on the question is, have you conducted any studies on what the continent can learn from the 2 recent outbreaks of Marburg in Rwanda and Tanzania? That's the first question. Then we have the second question about the Africa Vaccination Week that is underway. Are there any messages or special research findings that Africa CDC could share? Over to you, Prof.
Thank you. So I will hand over to Papa Musoka for the response that I can complement if needed.
Dr. Falla, you're on mute.
Sorry. For the Marburg in Rwanda and Tanzania, at least from Rwanda, we show that one can use therapeutic candidates and get it on time. So in Rwanda, we saw that remdesivir was used with some promising result. We cannot conclusively say that it was remdesivir alone. With optimum standard of care, we saw that working very, very well in Rwanda. And then with Tanzania, it was well popular intervention. We didn't get to applying the remdesivir, which we then use later on for Ebola Sudan. So it's beginning to show as a potential therapeutics. But the good news is that we work with scientists in Tanzania. They've developed a protocol to look across the spectrum of serosurvey, look at sampling of bat to track spillover events, and then also looking at behavioral study. There is a protocol being developed to look at the filoviruses in what they call the Great Lake region. We are looking at 7 countries in East Africa that have had recurrent cases of either Ebola or Marburg. It's a complex study. We are going to look at serosurvey. We are going to look at behavior, and then look at some ecological study across the multiple countries to be able to really understand why these particular countries have increasing recurrent number of the filoviruses, that is the Marburg and the Ebola. But if I would join my colleague, Professor Yap, it's multi-country. We're working on this as an inter-epidemic study that is very critical for the next study, as we saw in the case of the vaccine trial in Uganda. What this needs is funding and resources. But the good thing is that the scientists are working together. Even when I was in Tanzania, the physicians from Rwanda are willing to come to help us set up the remdesivir treatment. But we're going to do this multi-country, big clinical trial across 7 countries in the Great Lake regions. In terms of the vaccine week, we know that we're working hard to work on R&D for vaccines, but there is a big phenomenon we're having. Vaccine hesitancy is becoming a big issue. We are going more and more into operational and social science research, but we want us to reinforce the message that one of the greatest popular intervention in our life has been vaccines. Many of us today can attribute our life and our survival because of vaccines, and we need to change. We need to keep that momentum. We need to fight hard against vaccine hesitancy, this conspiracy theory against vaccine. We need to work hard. We need to generate more and more evidences to say vaccine saves. Vaccine is one of our biggest popular intervention in the history of humanity. We need to really work against vaccine hesitancy. Thank you. Over to you, Dr. Yab.
Yeah, thank you so much, Musoka. It's important to highlight that the immunization week, we're talking about Africa, but globally, we see some case of measles raising in France, in Europe, in many other countries. So it's really critical to remind that vaccine remain the most efficient tool to address some of what we call the vaccine preventable disease, including polio, including measles. And on the 24th to the 13th, Sierra Leone will be hosting the Africa Vaccination Week, which will be championed by the head of state of Sierra Leone as an opportunity to push the agenda of vaccination. We've been talking about Mpox, we've been talking about measles, but really to ensure that we keep the gain that we've managed to have thanks to the vaccination, and then we don't come back because of the vaccine hesitancy or because of the non-availability of vaccine. It is also the opportunity to highlight the local manufacturing agenda, which is supported by Africa CDC. 98% of the vaccine used in Africa are not produced in the continent, while Africa CDC is leading toward having at least 40% of those produced in the continent in the next few years. So this is the opportunity to push and to support the partnership for tech transfer, for investment, so that we reach a point where the continent have autonomy, independency in terms of immunization of its population. Over to you, Margaret.
Thank you, Prof. And with that, we have come to the end of the weekly briefing this week. We'll hand the floor back to you, Prof, for your closing remarks. Over to you.
Thank you. Thank you so much, Margaret. Thank you to all the colleagues that have joined, the journalists, the colleague in the field. So we are at a turning point where we really need to accelerate, as we mentioned, the response. Within a month, we'll sit down, we provide evidence to the ECG to find out whether we should continue the facts or not. And really, we hope that we'll have enough resource, enough vaccine, enough energy for the colleagues to respond to that outbreak and learn so that we can move from the identification to the legacy phase, as we've been seeing in Burundi. With those words, I really thank you. And we look forward to have you with us next Thursday at the same time. Thank you.